Good afternoon, and welcome to this month's Health Policy Grand Rounds at the Institute for Health Policy Studies. We do this webinar series monthly, generally on the first Tuesday of the month, with a few exceptions. And we are delighted to have all of you join us this week. So we would like to begin by acknowledging the Ramaytush Ohlone people, who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UC San Francisco sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. This land dedication is particularly important as it's Native American Heritage Month, and UCSF has many activities that you can learn about on the UCSF website. Today, I am delighted to introduce our webinar Grand Round speaker. Ariana Marie Planey is an assistant professor in the Department of Health Policy and Management at the Gilling School of Global Public Health at the University of North Carolina, Chapel Hill. She is a health and medical geographer with expertise in measuring and conceptualizing healthcare access. Her overarching interests include health and healthcare equity, with a focus on the application of spatial analytic, statistical, and epidemiologic methods to study interactions between health and healthcare policies, healthcare access and utilization, and underlying population level health inequities. And she identifies points of intervention at structural and system levels. At the core of her research agenda is equity in access and outcomes, with attention to the intersections of race, class, gender, and disability status. She also is a faculty fellow in the Cecil G. Shep Center for Health Services Research and the Carolina Population Center. She completed her PhD in geography from the University of Illinois at Urbana-Champaign after earning her master's and bachelor's degrees at the University of Chicago and the University of California, Berkeley, right across the bridge from us. Her current work is funded by the Robert Wood Johnson Foundation, National Institute on Drug Abuse, the National Institute on Minority Health and Health Disparities, and the National Cancer Institute. And I will note, I am really excited because I think Dr. Planey is one of the most innovative researchers in the field right now. So I'm looking forward to learning from her today. Thank you for joining us.
Thank you so much for having me. Thank you so much. I'm going to start sharing my screen. And I am going to try to allow as much time for questions if possible. All right. Okay. So, oops. So I mean, the title is Minding the Intersection of, here we go. Minding the intersection of time scarcity and financial toxicity. Well, sorry, everything's blocking my screen. Turn that off. Okay, here we go. Minding the intersection of time scarcity and financial toxicity. Studying cancer outcomes with attention to time as a social determinant of health. So the bio covered, thank you. The bio covered most of the details on this slide. But I did want to start by recognizing that my journey here is actually non-linear. I completed my undergraduate degree at Berkeley with the intention of going to law school. Graduated into recession, decided not to go to law school, interest generally shifted toward studying the intersection of policy and population health. Along the way, I thought, oh, well, why not try practicing? Why not try going on to clinical practice? And I was able to make that pivot because in my undergraduate degree, I had a pretty comprehensive liberal arts curriculum. So I benefited greatly from that because I had the science background to get into a clinical program. ultimately pivoted back to studying healthcare policy and healthcare outcomes. And now I'm in the School of Public Health, and I pivoted more or less from the social sciences to applied health services research and public health research. So as a medical geographer, a health and medical geographer, my content areas and methods focus include healthcare workforce issues. So generally answering the questions like where healthcare workers work and why, and then by extension, what that means for healthcare access. So equity and spatial access to care, access as a process, not just as an outcome. And one of my enduring interests is in Medicare and Medicaid policies, thinking about implementation and outcomes, particularly with a focus on healthcare access and outcomes. On the method side, spatial social epidemiology, spatial analysis, spatial statistics, spatial econometrics. I'm also a big fan of hierarchical linear modeling. But overall, my focus is on modeling with spatially referenced data that violate the assumption of independence and pairing those methods with health and healthcare related questions, because health and healthcare are always spatial matters. So for this presentation, it's going to be 4 parts. The first 2 parts are going to be a bit front heavy, and it's just a lot of laying the groundwork for even just to talk about my current work. So first, I'll say overall oriented, thinking more deeply about the cost borne by the cancer patient with an expansive definition of cost. And thinking also recognizing that there's an overlap between the work on time toxicity in oncology research with the work on time scarcity in the social sciences, but recognizing that it is there's some distinctive elements in multiple distinctive elements in those research areas. So for this project, I will start with an overview of the social scientific literature and some theoretical frameworks for thinking through time scarcity as a social determinant of health. So time is a social determinant of health. This is, I highly recommend Dr. Jamila Missioner's 2018 book, Fragmented Democracy, Medicaid, Federalism, and Unequal Politics. Highly recommend that book. The first time I read that book and I was reading the introduction, this quote stuck out to me. When those most affected by a policy are also most marginalized, it is worth stopping to think about how policy and polity interact. And ever since I read that quote, ever since I read this has sort of been the guiding light for my research. So I'm thinking of so in my research at the intersection of policy and population health, I try to always come back to this. And so thinking about time as a social determinant of health and what that means for healthcare, can't do that without a strong, core definition of structural racism. So structural racism, we can think of it as macro level systems, social forces, institutions, ideologies, and processes that interact with one another to generate and reinforce inequalities among racial and ethnic groups. And so that overlaps with time scarcity and the concept of time as a social determinant of health, because from prior research, we do know that communities of color bear a disproportionate burden of time scarcity. And so this quote actually touches on that. Because time is differentially allocated by race, time may account for some of the racial inequities in health. And conversely, this also implies that racial ethnic minorities potentially have the most to gain by interventions that promote time equity. And I'll give some more background here. And so as a geographer, of course, when I'm talking about time, I'm also talking about space. So you can think about it, there's a term in geography called friction of distance. And you can think about that in a more holistic sense of we live in a society where the spatial allocation of resources is reflective of who has power. So generally, when one of the most well-known examples of that is racial segregation, which we can also think of as the racialization of space or the spatialization of race. And so, like, what that does is it also introduces time inequities in the everyday lives of people of color, particularly those in segregated spaces. So they may live farther from well-paying jobs. They live farther from grocery stores. They may live farther from healthcare facilities. And what that means is they have longer work commutes. They would have to travel, or they would have to drive farther to get healthful food for their families. They would have to drive farther to get health care. So, like, thinking about these inequities in access to health enabling resources at the same time as there's a disproportionate exposure to health harming hazards, such as the case of environmental racism. And so, in this area of research, particularly at the intersection of policy and health outcomes, health and healthcare outcomes, and a less examined facet is time. So a lot of times in policy evaluation work, the emphasis is on whether an implemented policy achieved its stated aims and whether there were disparate impacts. But less examined are the time burdens of these social and healthcare policies and their programs, like particularly with regard to the administrative burdens and the costs that are imposed on those who can least afford the cost, but who are most in need of the benefits of those programs. And so what we see is that these inequities arise from pre-existing racially uneven distributions of resources, such as healthcare, social services, affordable housing, and jobs. And an example of this is a Government Accountability Office report in 2020 reported that per the analysis, they found that in the U.S., nearly 110,000 disabled people, about 1.2% of applicants for SSI, died prior to receiving a final decision about their appeal for Social Security insurance between 2008 and 2019. If you know anything about Social Security insurance in the application process, administrative burdens are built into the process. Typically, the agencies or the sort of the offices that are tasked with handling those applications, they tend to be underfunded and understaffed. And so typically your first application will be denied. And those who, mostly those applicants who are able to find legal representation to appeal the denial of their first application, though they actually much more likely to succeed. But people who are applying for SSI typically don't have assets. They often have to spend down their assets before they can even apply for SSI. So it's sort of a bit like the snake eating its own tail. So it just reinforces inequality. This process where the first application is denied, and that actually reinforces inequality among the lowest income people in this country. So I'm going to skim past this, but thinking about policy and time burdens, since about the 70s, there's been a sort of what's called a neoliberal experimental turn in U.S. policy making, which has been shown over and over to exact attacks on the most impoverished, and particularly those people who stand to benefit the most from social and healthcare programs. For example, we know that administrative burdens are associated with accessing healthcare, increase the likelihood of foregone care among Black and disabled patients in the U.S. In the context of the pandemic, requiring in-person appointments to continue eligibility for nutrition programs such as WIC and SNAP actually reduced the number of people on those programs rolls. We also know in states like Michigan and in Arkansas, I believe, work requirements for requiring up to 40 hours of active job searching to maintain eligibility for Medicaid were not shown to be effective for increasing employment among Medicaid beneficiaries. And in the context of the pandemic, cuts to unemployment benefits did not actually induce reentry into the workforce after pandemic job losses. And so like all of those are time taxes on low income and disproportionately non-white populations. So when we're thinking about time as a social determinant of health, or time scarcity as a social determinant of health, this is beginning with the fact that time is a resource that is socially patterned, and that patterning is fundamentally shaped by the spatial allocation of key resources, such as jobs and healthcare. And so, for example, for Black and Latinx people in the US, in addition to longer wait times, Black and Latinx people experience longer travel distances to needed care. They also experience longer wait times in emergency departments. And we also see the same pattern for Black and Asian people in the UK. So it's not specific to the US. Overall, people of color experience high degrees of time scarcity, which is attributable in part to the disproportionate occupational sorting into precarious jobs without paid sick leave, longer work commutes born of the spatial mismatch between where they live and where they work. And so in some previous work, we found that some colleagues of mine, we found that long work commutes force a trade-off between wages, commute times, and housing affordability. And those trade-offs are most severe for Black women, Black disabled women in the workforce. Moreover, in the context of higher chronic disease in Black and Latinx communities, time scarcity is also associated with greater difficulty in chronic disease management, such as diet modification. So there's an added context of supermarket redlining, where grocers followed white consumers to the suburbs amid white flight. So I always have this figure when I teach and when I talk about social determinants of health versus fundamental causes, because I want to make sure that we recognize that these are distinct concepts. They also have different sort of there's also a scalar distinction between these concepts. So at the macro level, at the macro social level, you have fundamental causes which underlie the social patterning of resources that drive health inequities and also underlie inequities in healthcare access. And a major fundamental cause is racial segregation. And you go down a level, you have social determinants of health. Everyone, I think we're all familiar with the concept of conditions in which people are born, grow, work, live, and age in the wider set of forces and systems shaping conditions of daily life. And down closer to the individual and household level, you have the concept of social risk and social needs. I distinguish these concepts. I know a lot of people in health services research, particularly on the health system side, do not. But I'm very clear that these are distinct concepts. So like social risk, social needs, that's typically what you're screening for in the sort of in the context of a clinical encounter. But they are distinct and actually downstream of social determinants of health and fundamental causes. So if time is a social determinant of health, then what do we measure? And these are three broad ideas. First, you can measure the spatially uneven and racially disparate distribution of harmful exposures, such as chronic stress in segregated neighborhoods, or exposures born of environmental racism, and their inequitable downstream effects. You can also measure time use, so such as the time cost of, say, commuting to work, accessing healthcare services. Or you can also measure wages. And when you talk about wages, you're always talking about time. So you can think about wages in terms of trade-off with commute times and housing costs. You can also think of wages in terms of how long does someone have to work in order to pay for the cost of living. So either way, in either sense, you're thinking about time scarcity. An example I gave earlier, disabled women of color, particularly Black disabled women, face the most severe trade-off between wages and commute times. There's a rich literature on spatial mismatch that jointly considers time cost with the social and monetary cost born of the allocation of resources that favors white and wealthy people in segregated social space. So when you think about time scarcity and implications for healthcare inequity or healthcare equity, and this particularly for rural residents, we have to recognize like there's a large body of research that shows that travel distance to care is a key barrier to healthcare utilization that affects both the frequency, timing, and cost of hospital visits, and also potentially affects health and healthcare outcomes. So we know that longer travel time to access care has downstream implications for patients, including increased risk of hospitalization for ambulatory care sensitive conditions or conditions that would otherwise be managed with access to preventive care, primary or preventive care. Longer ambulance travel times and worse survival rates for emergent conditions such as traumas and heart attacks. Lower rates of post-hospitalization follow-up care, a higher rate of emergency department use, particularly among people who've had surgery recently. And in the context of cancer, delayed diagnoses and worse severity of conditions, particularly in the case of stageable cancer. So delays at the screening stage, delays and a sort of longer time to treatment after the diagnostic screening and between diagnostic screening and initiation of cancer treatment. And so all of that, both of these delays actually have consequences for survival in the long term. The implications for cancer outcomes. So this is a study that I did with this awesome research team. I did not mean to move that fast, but this paper was published in Milbank Quarterly earlier this year, so I'm going to go over it pretty quickly. So we looked at, in the context of rural hospital closures, looked at access to both nearest acute care hospital and second nearest acute care hospital to get a better sense, a more holistic sense of population access to acute care across the rural South. And what we found was that residents in majority Black and majority Latinx rural tracts had the longest travel distances to the second nearest operating short-term acute hospital. And this is, I would contextualize this in the broader literature on hospital bypass, where people bypass the hospital that's nearest them. And so what that means, and so like, the propensity for hospital bypass depends on many factors. So patients who have more severe health states or chronic conditions may bypass their local hospital in favor of a hospital that's farther away. We also know that commercially insured patients are much more likely to bypass their local hospital. So this has implications for hospital finances, but it also has implications for the travel burden borne by rural dwelling patients. So here's map showing the additional distance that one would have to travel to get from your nearest hospital to the next nearest hospital. And those distances, so on the left is distance and on the right is travel time. And so those distances and times were actually greatest in Latinx communities and Black communities across the rural South. And so what that means is if you have a subset, if you have rural dwelling patients in the U.S. South, particularly those who are Black and Latinx, and then they're going to bypass the hospital, the travel burden associated with that choice is greater versus residents in places that are much wider versus those that are white, have higher share of Black and Latinx residents. So what we estimated that about 57% of rural tracts, residents in those tracts had to travel an additional 15 minutes or more to the next nearest hospital. And of those, about 2.5 million had to travel an additional 30 minutes or more to access to the next nearest hospital. And so in follow-up studies, and so another two things here is that it's a tract level proportion of Black residents increased, so too did the additional travel time to access the next nearest open hospital. We saw the opposite pattern for white share of population at the tract level in U.S. South. And what we found in our model was that the racial disparities in rural travel times are more apparent when we account times to the next nearest hospital. So when most studies only measure access to the nearest hospital, but they're actually underestimating the travel burden borne by rural dwelling residents. And so they're also underestimating the disparities, the racial and ethnic disparities in spatial access to healthcare services. We do see evidence that federal investments to improve access to acute care, particularly in the most remote and rural communities, we do see evidence that they have been effective, but we also recognize that those benefits have mostly accrued to predominantly white rural communities. And so in a follow-up study, we looked at these and those. So in the follow-up study, the inequities in access to acute care, access to hospital outpatient services at acute hospitals. That's the backdrop for this follow-up study. So we're looking at cancer screening receipt among rural dwelling residents. And so further context, we also account for county primary care HPSA status, so health professional shortage area status. And so what we know is that overall about 37.7 rural counties, U.S. counties were classified as either whole county or partial county primary care HPSAs. But of those, the majority were classified as whole or partial county HPSAs were non-metropolitan or what we would say rural. And what we found when we looked at spatial access to outpatient services at acute hospitals, we found that travel times to access nearest and next nearest hospital were greatest for rural tracts and counties classified as partial county primary care HPSAs, which is an interesting finding, and also it actually coincides with a paper that just came out in Health Affairs, which found that the HPSA classification hasn't actually appreciably increased the supply of physicians or improved population health outcomes. So what we're seeing is that counties, rural residents in partial county primary care HPSAs have poorer access to both primary care providers and outpatient services based at hospitals. That's in the context of rural hospitals becoming much more reliant on outpatient services for revenue. Okay, so in terms of research questions for this follow-up study, we are interested in whether longer travel time to acute care hospitals were associated with lower receipt of cancer screening among rural dwelling adults in the U.S. South. We're also interested in whether hospital closures in the prior 7 years were associated with lower receipt of cancer screening among rural dwelling adults in the U.S. South. And so we are working with the CDC released a data that was at the tract level, and it included BRFS, behavioral risk factors served by BRFSS data. And so we linked that with U.S. Census Bureau data for demographic and socioeconomic variables. And we used our prior estimates of travel time, so road travel times and travel distances to access acute care hospitals, and also added in health workforce variables from the Area Health Resources file. And we estimated 3-level mixed effect generalized linear models with variables at tract, county, and state levels. Our outcomes of interest, there were 3. So first was share of women who received mammography in the prior 2 years, share of rural dwelling women who received the cancer screening, cervical cancer screening. So either a pap smear or HPV test alone or pap smear in combination with HPV test, so co-testing. But the one limitation of that was that we were not able to differentiate between the different cervical screenings modalities. So that is one limitation of this data set. And the third outcome was the share of rural dwelling adults who received colorectal cancer screening in the prior 10 years. Covariates include social demographic variables, travel time estimates, healthcare supply variables, policy variables, and health county closure status. I'm just going to go very quickly over the results. We did find that longer travel time to acute care hospitals were associated with lower receipts of cancer screening among rural-dwelling adults in the U.S. South. And this was consistent with some prior research that I did a study done in Florida that showed that rural-dwelling adults who bypassed their local hospital or had to bypass their local hospital to receive colorectal cancer screening actually were less likely to receive colorectal cancer screening. So there is there's some nuance to the results, but overall we find that longer travel times were associated with reduced receipt of cancer screening. And we also find that hospital closures in the prior 7 years were associated with lower receipts of cancer screening among rural-dwelling adults. I didn't get into the literature there, but there's prior research that shows that there are reductions in the healthcare workforce in the wake of hospital closures that persist up to 7 years. And so our question was that does this affect the receipt of preventive care among rural-dwelling adults? We did find suggestive evidence, but the results were not statistically significant. And so this is also, I would contextualize this study in the broader body of literature and on rural access to oncology or cancer care. So what we found is that about half of rural residents in the U.S., or what these authors found, is that about half of rural residents in the U.S. had to travel 60 miles or more to reach their nearest colorectal surgeon, gynecologic oncologist, or surgical oncologist. And about over 10% of rural residents have to travel at least 2 hours to get to a physician specializing in colorectal surgery, on gynecologic oncology, or surgical oncology. And we also know that the locations of cancer centers tend to favor more urbanized areas. And you'll see later that in some of my ongoing work, we find that that patients receiving care in urban areas actually travel much farther than patients receiving care at urban cancer centers versus patients receiving care at rural cancer centers. And I can get into the reasons why. This is getting to my more recent and ongoing research. So studying the joint effects of financial toxicity and non-financial cost of care access among rural cancer survivors. This is a collaboration here at UNC with Stephanie Wheeler, a professor in health policy management, cancer outcomes researcher extraordinaire, Don Rosenstein, who is a oncologist, psychiatric oncologist, and he does a lot of work on financial navigation and sort of at the overlap between sort of the mental well-being and the cost of cancer care. And Lisa Spies, who's also a faculty member, but she's in the School of Pharmacy now. So this was this is part of a broader intervention study called Lessening the Impact of Financial Toxicity. We have 10 study sites now across North Carolina. I think about 5 are rural and I want to say 5 are urban and 4 are rural. And so the design of the study was meant to look at the impact of financial navigation on on reported distress among cancer patients or cancer survivors who screened positive basically for financial toxicity. So you understand the cost measure. And my project supplemented this parent project. And so in complement to the parent grant objective, which is to evaluate the implementation and effectiveness of financial navigation within rural and non-rural cancer settings, this project leverages that research infrastructure to further map out the effects of financial toxicity on healthcare help seeking among rural dwelling cancer care cancer patients and survivors across these intervention sites. And hope, like the end goal, is to adapt existing models of healthcare help seeking to explain healthcare access and utilization and understand how rural cancer survivors, in the context of this financial navigation intervention, access care. And part of that is also understanding how they conceptualize travel burden associated with accessing and using healthcare services. So the project objectives included exploring the relationship between financial toxicity and the travel barrier, the spatial barrier to care prior to and after the receipt of cancer diagnosis among rural cancer survivors, patients and survivors. And the second objective was to analyze the association between travel burden associated with cancer care and the level of financial toxicity among rural cancer survivors. And the third was to examine the relationship between financial toxicity and care continuity among rural cancer survivors, controlling for spatial access to care. So in terms of where we are in the cancer, like the continuum, we're toward the end. So looking at cancer treatment, active treatment, survivorship, and end of life care. So important context. I think I haven't explained what financial toxicity is. About a third of cancer patients in the U.S. have incurred higher than expected costs associated with cancer care, which leading to financial distress. Financial toxicity, which is related to financial distress, is defined as patient-level impact of the cost of cancer care, and is independently associated with increased mortality among cancer patients. In the growing body of literature on financial toxicity, the costs of cancer care have been defined in more holistic ways to include non-monetary and indirect costs of care, such as opportunity costs imposed through time off for appointment, compounding monetary costs, such as child care, hotel costs, parking fees, car maintenance, gas, you name it. And so then we can think about financial toxicity as an impediment to equitable care access, quality, and outcomes, which can compound the cost of access and care. And so this is a helpful framework for thinking through that relationship between financial toxicity and healthcare outcomes, health-related quality of life among cancer patients. So these costs of these direct and indirect costs of medical care, they affect the ability to pay for healthcare services. They affect one's psychological well-being. They also shape behavioral or decision-making with regard to cancer care. So people experiencing cancer-related financial toxicity are more likely to skip medical visits, forego medication, and delay say surveillance screening, and delay other kinds of treatments. And that results in reduced well-being and quality of life, increased likelihood of morbidity and mortality. Important modifiers include economic status, but another potential modifier may be time availability or time scarcity. And so this is so that's part of I don't know if you all know the concept of 5 A's of access. So thinking about access as multidimensional, and there's 5 A's. So there's availability, accessibility, accommodation, affordability, and acceptability. So far, I've been mostly talking about affordability. I will also be talking about accessibility in the sense of thinking about travel burden. So the cost of accessing care, the indirect cost of accessing care borne by cancer patients. So focusing on access as a process. So most definitions of access treat access as an outcome or an event or an episode. So typically access is conflated with utilization or service use, or it could also define as entry into a health system. I think that's implied in the IOM model, actually. There's also a related tendency to focus on patient or behavioral characteristics that make help seeking and utilization more or less likely. but there's less attention to care coordination and continuity in the management of chronic or comorbid conditions. And so then it's like, and that's important, particularly because we have a growing burden of chronic conditions in the US and elsewhere, particularly where with population, the aging populations are becoming a larger share of the overall population. And so it's important to think about access as an iterative process rather than as an outcome. So moving beyond those episodic or acute conceptions of healthcare access and utilization and toward a model that captures barriers and facilitators of coordinated continuous care. And with that could actually allow us to be better able to better conceptualize and measure how financial toxicity interacts with the complex process of access among rural cancer survivors. In this project, I define travel burdens as the cumulative temporal and financial cost of travel associated with cancer treatment receipt. And I also understand that these can exacerbate the temporal and financial stressors and constraints borne by patients who are currently in treatment for cancer. So, for example, chemotherapy is depending on the cancer site, it's a very intensive treatment course. It can mean weekly, bi-weekly visits to clinics. And so that definitely adds up if you have to travel farther for care. That definitely adds up if you have to relocate so that you're closer to care. So that either way, your patients in treatment are taking on an added cost to remain in treatment. And so we can understand travel burdens for cancer care in the context of disparities in timely receipt of cancer screening and diagnosis, which are partly attributable to broader inequities in spatial access to screening services. So these disparities have consequences that reverberate across the continuum from cancer stage at diagnosis for stageable cancer to prognosis and survival. And so here's the IOM model, which defines healthcare disparities as it actually excludes inequities in access to care from their definition of healthcare disparities. I actually argue that these inequities in access to care actually shape healthcare outcomes and help shape those healthcare disparities because how you enter care also influences how you receive care. And we see this across the care continuum in terms of cancer, particularly among patients who have delayed diagnoses and longer time for treatment, and how that has a long-term influence on their survival and prognosis and survival. We see that in colorectal cancers especially. So this is addressing the facet of accessibility. I'm going to move through. So I haven't. We are still recruiting. So for the AIM-1, I'm doing semi-structured phone interviews with participants in the study, and to explore the spatial barriers to care prior to and after receipt of cancer diagnosis among rural dwelling cancer survivors and patients experiencing financial toxicity. And so I'll talk a little bit more about what I'm finding so far. And this AIMS 2 and 3 are going to be more retrospective analyses after we're done recruiting. So it'll be a secondary analysis of survey responses. So we have the cost measures, we have the promise measures. So we have patient-reported outcomes. We also have measured level to financial toxicity. So that's also helpful. We also have information about the frequency of their appointments, what kind. So given us a lot of information, and also I've also added in information about how far each of these participants are traveling based on their residential location and where they're receiving their cancer care, where they're receiving their cancer treatment. So all of these participants are receiving care at the 10 participant sites in this intervention study. And the AIM-3 will be looking at examining the relationship between financial toxicity, care continuity among rural cancer survivors, and controlling for spatial access to care. Haven't been able to get to that part because we're still in recruitment phase. I'm going to keep moving and just kind of talk about some preliminary findings. So the intervention or study participant, actually what we found is that those at rural sites had longer travel distances and times versus the participants at rural sites. So participants at urban sites had longer travel times and distances versus those at rural sites. And so that's just something that was initially not accounted for in the original study design. So what I added was a finer grain focus on the distinction between rural cancer center, urban cancer center. So just because you have a rural cancer center or an urban cancer center, that doesn't mean the people receiving care are rural or urban. What we see is that, again, kind of alluding to what I was talking about earlier, what we see is that rural dwelling patients will bypass rural sites to receive more specialized care. And we see that in the case of oncology or cancer care receipt. So I'm not expecting you all to read this, but this is one of the outputs from our studies thus far. But we found that rural dwelling LIFT participants had longer travel distances to access the cancer care sites. But rural dwelling participants who received care at urban sites had the longest travel distances by far. So those rural dwelling participants receiving care at non-rural sites had mean travel distance of about 43.4 miles, compared with 33.4 miles for those their counterparts compared with about 12 miles for those receiving care at rural sites. So among rural participants, the travel distance for those at urban sites was 43 miles versus about 12 miles for those at rural sites. And so this kind of speaks again to the piece about bypassing rural facilities for urban facilities in the course of receiving more specialized care. And while we're waiting for recruitment to finish up, I actually started up a scoping review of the intersection of financial toxicity and travel burdens. And emergent themes include cancer treatment outcomes, so thinking about survival, also treatment decision making, so that behavioral aspect, so how that intersection of the financial toxicity and the heavy travel burdens influence treatment decision making. So that includes the site of care, so the choice between high volume versus low volume cancer centers, academic medical center versus non-academic medical center. That also influences patient decisions between the choice of radiotherapy versus chemotherapy versus surgical treatment for their respective cancers. And of course, we know cancers are heterogeneous. The recommended treatments are heterogeneous, but we also know that radiotherapy and chemotherapy are very intensive forms of treatment that have cumulative costs that patients actually. There's some research showing that cancer patients will actually weigh those costs of accessing care over the potential benefits and survivorship. So, for example, surgical treatment, a cancer where surgical treatment is not recommended, patients choosing surgical treatment are often thinking about the financial cost of cancer care and opting for the least intensive form of care. And then another outcome born of these influences on treatment decision making includes treatment discontinuation. On the patient side, thinking about health-related quality of life, such as mental health outcomes, and social support and unmet needs. And this is where caregiving it also comes in. So thinking about that dyadic relationship and how those costs that are borne by the patients are also borne by people in their social networks. And the last emergent theme is propensity to participate in real and clinical trials. There's also studies, sort of basically secondary analyses of RCTs. They're kind of retrospective looks, and they're seeing, okay, so who isn't participating in our study? And what we see is that these more rural participants who like to travel farther, who are not receiving support to enable their, to defray the cost of transportation, to defray the cost of cancer care, they may actually be less likely to participate in trials or less likely to stay in the trial once they consent to participate. And so there's a couple of ways we can think about this too. Travel burdens for cancer care can also be a moderator for the relationship between financial toxicity and patient outcome. And so two examples, patient choice of radiotherapy, which is the recommended treatment for soft tissue sarcomas versus surgical treatment. So what we see is in these, among patients with soft tissue sarcomas, those who chose surgical treatment over the recommended radiotherapy tended to be more cost conscientious or cost aware. And we're also weighing the time cost of the iterative treatment in the form of radiotherapy versus the one-time treatment in the form of surgical treatment. And in the case of breast cancer, among rural-dwelling breast cancer patients, greater distances from radiotherapy facilities is associated with lower likelihood of opting for breast-conserving surgery. And we see this particularly among rural-dwelling Black women. So thinking about those additive costs of travel and the financial cost and how that influences the treatment decision-making. So part of that part of that is that the radiotherapy facilities may actually be more accessible to these participants, these rural-dwelling participants. We can also think about travel burdens for cancer care as a mediator of the relationship between financial toxicity and patient outcomes. And one example of this is among patients with early stage glottic cancers. So this study found that the compounding indirect cost of radiation therapy was consistently higher than that for endoscopic excision, resulting in more missed work hours, longer travel times, and greater travel distances traveled by these patients. And so, like all together, those are much higher cumulative costs borne by patients. Let's see. And so, in interviews, structured interviews with rural-dwelling cancer patients experiencing financial toxicity. There's been a few emergent and unexpected themes. Some expected, some unexpected. So this first one is certainly expected. So uncertainty and anxiety regarding unpredictable cost of cancer-related care. Also just shared burden. So thinking about that social support, the caregiver support, particularly in the context of those dyadic caregiving and care receiver relationships. Changes in care experienced amidst the COVID pandemic. And also the impact of Medicaid unwinding at the end of the public health emergency. And I have one quote that really stuck with me. So then I'm on Medicare. So this participant was dual eligible, rural-dwelling, dual eligible, traveled 4 hours round trip to access cancer treatment monthly. His mobility was constrained because he had a bone cancer that resulted in partial paralysis. So he could no longer drive himself. So that actually greatly increased the burden associated with travel and accessing healthcare services, particularly when he needed them most. So here he's talking about he was dually eligible. He was on both Medicare and Medicaid, but when sometime around this year, beginning of this year, with the end of the public health emergency, he lost his Medicaid coverage. He said, "So I'm waiting to be I have Medicaid or had Medicaid, but I'm waiting for it to be reinstated because you know." In North Carolina, they got a bracket where you make a certain amount of money, and well, I'm in my spend down period now, and they haven't passed the Medicaid expansion yet. This was about a week before Medicaid expansion was passed in the legislature, and I have to go to spend down. So that's a period where I may get no help, and so this actually brings together. Um, the shared burdens theme and the Medicaid unwinding at the end of the public health emergency theme, where he's talking about to to demonstrate his eligibility for Medicaid, he had to stop accepting assistance from his family. So his family was his brothers, his sisters, his nieces and nephews. They were all pitching in to help pay for his medications because he had three medications that were not covered by Medicare. They were pitching in to pay for his transportation to get to his medical appointment, and they were also helping to pitch in to pay for his food. Um, so he had just enough to cover housing, but he needed assistance with all these other costs of living. However, when he lost his Medicaid coverage due to the redeterminations, um, and now now has to go into a spend down period to demonstrate that he does indeed need Medicaid still. Um, he he cannot accept assistance or help from his family because that counts against him in his applications for Medicaid. So this sort of speaks to the importance of policy for population health. And it's like important, it's like particularly in the overlap where you're looking at healthcare access and healthcare outcomes. And so this is where so the final part of this project is really going to be expanding existing models of healthcare access to more explicitly account for that overlap between the lack of affordability of healthcare services and the accumulating burdens, accumulating costs of accessing healthcare services. So I think I can stop here for a while. I don't know how much time. Oh my God, we're at time. I'm so sorry about that.
No worries. If you're able to stay for another minute or two, we have one question that's come in the Q&A so far. So if you have a few moments, would you entertain that?
Oh, I'm here. Good.
Right. Let's see. So a question came in asking about travel time estimates, and I think this is a general methodological question about accounting for the use of public transportation versus driving and wait times for public transit.
So this was driving time, but you were right. The public transit travel time for public transit can be much higher, particularly if you're looking at rural places which typically do not have public transit. So they might be using paratransit, which is even less frequent. So in the case of this participant, the study participant I read out, he was taking paratransit, and he had to actually be at the bus stop for 3 a.m. if he wanted to be at the doctor for a 9 a.m. appointment.
Yep.
So
totally, yeah. And I think rural areas, as you point out, are especially lacking efficient and frequent public transit. And I've heard many people quip about like Los Angeles, where the public transit networks, even though it's very urban, the public transit networks are not very good. So it can be a big burden, and that maybe isn't measured. Maybe makes your results even more striking if you could measure that. Let's see, another question. Thanks you for this interesting talk, and would be interested in hearing about exciting research opportunities that you're thinking about at the future. at this intersection of geography and health. So where do you imagine going next?
That's a really good question. I think I'd like to move towards a health services research, a vision of health services research that more explicitly accounts for the burdens borne by patients. And I think I kind of started getting into that in the context of like hospital closures and mergers and what that means for patient access to care and affordability of care. So, for example, in the case of mergers, we know that mergers are typically associated with increased healthcare prices, which has downstream implications for the debt burdens associated with healthcare use and also foregone care among people who need it because they're more cost conscious. So I guess my vision, I see a vision of a health services research that is more patient oriented, um, but still very much focused on health systems and their impact on population. And I think there's a lot of opportunity to bring in geography in that in a research agenda, much like that one.
Well, I don't see any other questions in now, other than Jennifer Yarger, who's an assistant professor with us, thanking you for sharing your really interesting research. And I join her in thanking you for a great presentation. For those of you who are still online, this has been recorded and we will be sharing it. And I'm sure that Dr. Planey is available for questions via email. Although she also is very busy. So I'm sure that everybody will forgive her if it takes her a little bit of time to get back to everybody. So thank you for taking the time with us. And I look forward to running into you in person, hopefully over this next year at a conference or something.
Maybe.
All right. Thank you, everybody, for joining us for this month's Grand Rounds. And we'll see y'all here again next month.
Take care.